Hello, everyone. Welcome, welcome for today's event. Today's presentation is titled Hospital Compare Journey to Five-Star Status. My name is Seema Rathore, and I'm going to be your facilitator. I have Laurie in room to help me facilitate today's events as well. Next slide, please. One more slide. This session is being recorded and a copy of the slides will also be posted on the website. Next slide, please. Before we get started, can each of you please indicate which state you are from? Next slide, please. Let's get started with some housekeeping items. We would like for everyone to be able to participate in the question and answer session using the chat feature. Feel free to use this feature throughout the webinar to share your thoughts and post questions. When click on the chat window will appear. It will be on the right if you are not in the full screen. Please refer to a screenshot if unsure. If you have joined Zoom meeting using the web link, please use a microphone or call in using a phone. Web link and phone numbers are in the registration information. Next slide, please. At the end of today's presentation, you will have an opportunity to complete survey questions. This would help us to improve the session for next time. Before we go on, I would like to introduce today's first speaker, Linda Griscoll. Linda is the Quality Improvement Director for HealthInsight Nevada and oversees quality improvement programs. She is also the state lead for the care transitions and readmissions program, with the emphasis on addressing the opioid crisis in Nevada. Linda has worked with hospitals and physician groups across the country for more than 20 years in various analytic and consulting capacities. She has a bachelor degree in sociology with an emphasis on healthcare studies and a master's degree in healthcare administration from the University of Nevada, Las Vegas. Our second speaker is Holly Nickerson. Holly started her career at Ashanti Rogue Regional Medical Center in Medford, Oregon as a certified nursing assistant in 2006. Upon graduation from nursing school, she took a position in the cardiac intensive care unit at ARRMC. She has held a variety of leadership positions, including charge nurse, clinical coordinator, continuous improvement coordinator, and most recently as director of accreditation. In June of 2018, she assumed the role of director of quality for Asante Health System. Holly has oversight of continuous improvement, accreditation services, performance improvement, infection prevention, ambulatory quality, stroke program, bariatric program for Asante Health System. Holly holds a master's in business administration from Oregon Health and Science University and a black belt in Lean and Six Sigma from Purdue University. Next slide, please. Linda, it's all yours.
Thank you, Seema, and welcome everybody. Thanks for coming today. So today we're going to walk through the hospital star rating methodology and help you discover opportunities for improving your hospital star rating. On the next slide here, if you were to go to the Medicare.gov homepage, on the right side you'd find a tab for resources that helps with a list of tools to help consumers identify providers and make decisions on quality providers based on their outcomes. And in that area, you'll see a variety of settings are represented. They have information for hospitals, nursing homes, home health, dialysis centers, long-term care, inpatient rehab, doctors, hospice care, health and drug plans, and where to get covered medical items. So the top 4 areas there also have comparison websites. So you're very familiar, I'm sure, with Hospital Compare, but there's also Nursing Home Compare and Home Health Compare and Dialysis Facility Compare. And all these areas also have star ratings. So far, the other areas do not have a star rating. That may be something that comes in the future. But right now, it's just these top 4 areas that also have star ratings. The ratings look a little bit different. Some of them have several stars, and the methodology is a little bit different. But today, we're going to be focusing on hospitals and the hospital star rating system. So, next slide, please. So on Hospital Compare, they collect quality information from more than 4,000 Medicare certified hospitals across the country. And this includes short-term acute care hospitals, critical access, children's hospitals, and more than 130 VA hospitals. But not all hospitals are included in the star rating program yet. So basically in the star rating program, that includes short-term acute care and critical access hospitals if they're eligible for a star rating. Next slide, thank you. The goal of the hospital star rating system is to improve the usability and interpretability of all that information that's posted in Hospital Compare. All short-term acute care and critical access hospitals are eligible to receive a star rating if they meet certain criteria. And this system hasn't been around for very long. The first star rating was released in July of 2016. Next slide, please. So I'm going to kind of walk through the methodology of how they come up with your star assignment for the hospitals. And I'm going to kind of walk through the details, and then on future slides, I'll try to break it down and provide visualization. But basically, the star ratings, out of over 100 measures that are available in Hospital Compare, they single out 57 measures to composite your score for a star rating for your hospital. And that may change to 59. So some of the graphics in here you'll see will go back and forth between 57 and 59. But as of right now, it's officially 57 measures. And that used to be like over 70 measures. So they've reduced that quite a bit. But basically, they select and standardize measures collected through hospital inpatient and outpatient quality reporting programs, through HCAPS and claims data and other reporting systems, and then the measures are standardized. And then they group measures into 7 categories, with outcomes and patient experience measures weighing heavier than the others. And then they calculate a group score for each of the 7 categories and combine the 7 scores into one composite score for your hospital. And then they turn those composite scores into star ratings and put using a clustering method and assign all the hospitals into a rating of 1 through 5 stars. So on the next page here is a little bit, is a graph. So some of us are better visual learners. So I'll walk through it again. So basically, the first step is a selection process to see which measures each hospital is eligible for based on selection criteria. They look at the 57 measures, and then if your hospital is eligible for that measure, then they group these measures into 7 categories, and we're going to dig into those 7 categories a little bit deeper. But basically, shown here in the second column in the purple: mortality, safety of care, readmissions, etc. And then each group receives a group score based on your outcomes and your hospital outcomes. And then they take those 7 group scores and generate a hospital composite score. And then before they assign stars to the hospitals, they first test for criteria or for eligibility. So hospitals must report 3 measures in at least 3 measure groups, and one of those groups must be an outcomes group. And if you don't meet that threshold, then your hospital is removed from the group, And then the remaining eligible hospitals are assigned stars on a system of 1 through 5, and with a larger portion of the hospitals receiving a star rating. So in the past, before the December 2017 release, this last measure, that step 5, they did it a little differently. They would assign all the hospitals into one of the 5 categories, star categories, and then they would remove ineligible hospitals. So now they remove those hospitals that don't have enough data to meet the criteria before they distribute the stars. And so the result of that is sort of a flattening of the bell curve, where we had less 3-star hospitals and more 1- and 5-star hospitals across our country. On the next page here, let's look at the groups a little bit more closely. So the 7 groups for the rating system includes mortality, safety of care, readmissions, and patient experience. And those 4 groups are weighted heavier at 22% each. And then the remaining 3 groups of effectiveness of care, timeliness of care, and medical imaging, each of those groups weigh in at 4% each. And then again, the reporting threshold is 3 measures and at least 3 groups, and one of those groups must be an outcomes group. The next slide, please. So data on Hospital Compare is updated quarterly, but although not all the measures will have updates every quarter. This link here will take you to the data that's included in Hospital Compare currently, so you can see where does the data come from that's being shown right now. And then the overall hospital star rating is scheduled to be updated twice a year in July and December. And we just received notice recently that the July release has been put on hold, has been delayed because CMS is collecting feedback from hospitals and they're examining potential changes to methodology. So I encourage you all to go through QualityNet and look at the feedback questions, and this is your time to have a voice in that methodology. And so the star ratings that are currently released that came out in December of 2017, those will remain in the public view until the next release of the star rating, which I would assume it could be October, but I'm going to assume they're going to do what they did last year and release it again in December. So before we move on to the next slide, let's pause here. And if you could just chat in the chat room, I'd like to just kind of take a quick poll on what is this, in your hospital organization, what is the priority for your star rating? Is that high priority in your organization? Is it something that everybody's talking about lately, or is it something that you don't hear much about? So just kind of chat in if you can. You know, is this high priority for you? Maybe it is because you're here today. Thank you, Pamela. High priority. Extremely high priority is yes, yes, high. High, it's a priority, but not a high one. Okay, that's okay. Well, thank you all for responding. Yes. Well, good. And I think that's why, you know, I'm hoping that's why you're here today. Not a high priority for us, somebody mentioned. About a medium priority. So that's the, you know, when I go out in the field, I kind of ask that question because I do like to learn, you know, what is, how important is this to your leaders? And is this something that everybody's talking about? Or is it something that you just don't ever hear anything about? And I've met with some leaders that didn't even know what their star rating was. So it's kind of all across the board. So I'm happy to hear that for the most part, many of you had rated this, consider this to be a high priority. So in the next few slides, we're going to dig a little deeper into these 7 groups, and we're going to look at the measures, the 57 measures that make up each group. And I'm not gonna go through line by line and read the measures, but there's a couple of things I'd like to point out in each group. So in the mortality group, this is one of the heavily weighted categories at 22%. So in each measure, it has a minimum of 25 cases for the collection period in order to be calculated in the group measure. So for each line item here, there's a minimum of 25 cases across, in this case, a 3-year period that you would need in order to have that measure eligible for the group. And in some other group measures and process measures, the minimum is 11 cases. So here for the data collection period, you can see for the most part, this is like a 3-year period to collect these cases. And then on the next slide, safety of care. So here, look again now, this is a list of 8 measures. Let's see how the data collection period here is often 1 year of data. So if you look down, and then it changes. So the last couple of measures have different collection periods. And so that's, just to kind of highlight, so when I hear the question, what can I do to impact my star rating now? And how fast will the work that I do, how fast will it show up in my star rating? So looking at the variances in the data collection period is kind of the answer. So not only is there like a 1-year lag, there's also 2 other years attached to your work. So for example, if you perform poorly for 2 years on something like readmissions, but then you perform superbly on 1 year, on the 3rd year for readmissions, it's going to take a while for that to catch up because there's clumps of multiple years in there. So basically, but my point here is this is not a sprint. This is more of a marathon. It takes a longer time for your good work to show up in the results of the star rating. And it's also important to remember that you're measured against other hospitals in the country. So when they assign all the hospitals into the star book, it's relative based on what everybody else is doing in the country. So if your hospital stays at status quo and doesn't make any change, you could actually lose a star rating if more hospitals are actually improving over time. So on the next slide on readmissions, what I'd like to point out here, so you're familiar, I'm sure, with the hospital readmission reduction program. So these measures here will look similar to what that program looks at, but it also includes stroke and hospital-wide readmissions of unplanned visits. And if you look at the last measure there, this is a new measure that was added, the rate of unplanned hospital visits after an outpatient colonoscopy. On the next slide, this is the patient, and that readmissions group was also rated at 22%, so that was a higher rated category, as is this patient experience category, 22%. So what I'd like to point out here is if you look at these measures, it's basically speaking to communications and medications explained and discharge instructions, and did the patients understand the care plan when they left the hospital. So basically, these are care transitions questions. So if you can improve in this area, then you can actually affect your readmissions rates as well at the same time. And both of those are rated highly at 22% mark. And then in the next 3 groups, I really don't have anything to point out here other than these are the lower rated groups. Lower weighted groups at 4% each group. So effectiveness of care, and then we have timeliness of care on the next page, and then medical imaging on the following page has 5 measures. So, and again, you're gonna get a copy of these slides, so you can go through those in more detail, line by line, so you can see what all those measures that are included in those groups. So again, to speak to eligibility, first of all, Hospital Compare has overall ratings for about 80% of the hospitals. So 20% of the hospitals are not rated because they did not meet the criteria for eligibility. your hospital would need measured a minimum of 25 cases in a collection period to be calculated in a group measure, or 11 if it's a process measure. And hospitals must have data on 3 measures and at least 3 measure groupings, and 1 must be an outcome category. So due to the number and the type of patients that you treat at your hospitals, some hospitals may not report data on all measures and therefore may not be eligible for a star rating. And we see that a lot in our critical access hospitals. So before we continue, I'm going to ask another question in the chat room. I see there's a little activity going on there, so I'll have to look back and see. Hopefully I didn't miss anything. But one more question, if you could please chat in the room. So a lot of you had this as a high priority, a star rating is high priority or medium priority in your organization. Can you tell me who, in terms of the title or the role, who in your organization is responsible for your star rating? So whose shoulders does that fall on? And just kind of put your answers in the chat box. All of us, quality control, CEO, leadership, everyone, I'd like to see the everyones. All led by the CEO, that's good. That's good. So I didn't see any, I don't know, so that's a good sign. I have, but again, been out in the field and I have heard that. So, well, I think it falls on my shoulders. I don't hear anybody talking about it, or it's not real clear. So I love to see that leadership is kind of has the message here. It's everybody's responsibility. Quality improvement monitors, we're all accountable. And it sounds like a lot of times the CEO is overseeing that.
Linda, can I ask a question?
Sure.
So when you were saying that, like us critical access hospitals may not have enough data for us, we actually have enough data for most everything, except for we don't report to NHSN, so we're not able to get data on the safety measures. So does that affect our rating in a negative way of our star ratings if we're not able to contribute data to that one area?
Well, it may not, if you're not contributing data, then they're not going to see it, and it won't be counted, and could make you ineligible. So if you don't contribute the data through NHSN, they're not going to be able to see it.
Yeah, for our overall rating, we have all the other data elements in there. So we have the readmissions and the mortality and everything else, and we have a star rating, but it says not applicable for the safety data. So I'm just wondering if that would hold our star rating back because of that.
Well, you know, in a few slides, I'm going to go into a little more detail on how you can dig in and identify what may have happened. So if you stick with me here, and I'll walk you through the next few slides, and we'll see if this answers your question. If that's all right?
Sure.
Okay.
Linda, before we move on, there is one more question. Are all the measures within a category weighted equally?
They are. They may have more of an impact. The weighting is the same, but they may have more impact. So I'll show you that in one of the last slides here on table 4. We're going to go through these hospital-specific reports, and I'll show you that, and I think that'll answer your question as well. So hospital-specific reports, or HSR reports, or sometimes they're called preview reports. These come out 30 days prior to your star rating becoming public. So you have 30 days to review the data and look, just kind of submit questions about the calculations, request a correction if there's an error identified. This is not really the time to be submitting corrections for claims. This is just to look at methodology and the results. And CMS will notify you of the exact dates of the preview period, and we'll post these dates on QualityNet. And by default, the CEO of the organization and one other designated security administrator has access to these reports. And you can add people to that, but by default, if you're in your organization trying to figure out who has access, for certain your CEO does have access. So on the next slide, we're going to go through, so this is a generic report that I downloaded, and it kind of shows, it's an Excel file, and it shows 4 tabs. So this would be the first tab that kind of shows, so this is your hospital star rating. You received 4 out of 5 stars. This is your summary score and the confidence interval for lower and upper interval limits. And then this is how you compare it to the national average. So pretty straightforward there. On the next table 2, this looks at the measure group scores. So it shows the 7 groups, and it shows typically how many measures are in the group, and then it shows how many measures were in that group for your hospital, how many of those measures you actually were eligible for. It shows the weighting of each group, and then the weighting for each hospital. And that may vary for your hospital, because if one of your groups you were ineligible for because you didn't have enough measures in that group. So for example, the use of medical imaging, if you didn't have enough to be eligible for that group, that 4% would be reassigned to all the other areas. So all your other weights would grow a little bit. And so then it shows you your measure group score and compares you to the national score, and then it just kind of summarizes, were you above or below or the same as national for each group. And then on the following table 3, this looks at each individual measure score, and this is only a partial table showing here, but this would list every single measure, and it shows again your hospital's result based on hospital compared data. It shows the national mean scores, and then how you deviated, the standard deviation across all hospitals from the national mean. And it shows your hospital's standardized measure score. So you could look through and see how you compared for every measure, which measures were ineligible, which weren't, measures you had 0 cases, or if it's being accounted for in the process, if it's being calculated into your final score, and how you compare to national. And then I think this next table, is to me the most telling, in table 4 on the next slide. This one kind of goes through all the measures again and lists, this is again partial table showing, but it shows this loading coefficient on the right-hand side. And basically, and I'm just going to read this, kind of what that means. So measure loadings should not be interpreted as measure weights. A measure loading is an association between an individual measure and the group score for the given reporting period. A larger loading coefficient indicates that a measure has greater impact on the measure group score. So basically, to answer your question, these measures are not weighted differently, but it could have a bigger impact. So it has just a slightly different meaning, but everybody's weighted the same, but it could have a larger impact on the group score. So basically, if you say, I'm committed to improving my hospital star rating, where the heck do I start? There's 57 measures. We can't work on all of them at once. So where do we start? And this is one good place to start to look, and you can look at where you can make the most impact, especially in those higher rated areas. So let's pause here. I'd like to ask a question in chat. So do you have access to these HSR reports in your hospital? Is this something you're using that you have, yes, I've heard of them, we use them, we look at them? Or is this something that may be new to you and I don't know what you're talking about, I've never seen these before? Or maybe you don't know who has access to that. So if you can just kind of type some responses in the chat. Okay. No, I would like to discover where to find these. Yes, we review these. Yes, we use these. They're discussed by the executive team. That's wonderful. Good. I'm glad to hear that. No, not currently, but we're starting to use these. No, but I'd like to. So this is something, when we talked to CMS, we had a live program on this in December in Northern and Southern Nevada, and I asked this question to the group of quality leaders, raise a hand of who is currently using these reports. And I don't know if they were shy in both cities, but no hands went up. And it was a little bit shocking. It's like, this is, of all people, you all need to be using this. So when I mentioned this to CMS and I said, do you know that we have a lot of people here that don't even know about these? And they said, yes, that they are aware, that it's just not, they're trying to bring more awareness to these, but there's maybe a 50% utilization rate of these reports, and they're so valuable because they show you your own data back at you, and they show you opportunity. So that's what we're trying to do. HealthInsight is trying to raise awareness so that everybody can utilize these reports and know where to find them. So thank you, everybody, for responding. So on the next section, we're going to talk about, in July of 2017, a study came out by Deloitte, and they basically went through the star ratings that were released, and they did some analysis to try to tease out, well, what are the 5-star hospitals doing? What are they doing differently, and where are they performing better to make them a 5-star hospital? So these next few slides are the results of their study. So hospitals that earn a 5-star rating generally outperformed lower rated hospitals in the heavily weighted categories. Among 5-star hospitals with sufficient data to report the safety of care category, 64% received an above the national average score for that category. And then hospitals that perform below national on lower weighted measures can still get a 5-star rating. So on the next page, let's look at the impact on readmissions. So 50% of 5-star hospitals received an above a national average score on readmissions, and only 1% of 1-star hospitals received that above national score. So readmissions can have a good impact on the results. And the next slide looks at three different hospitals, A, B, and C, and these are all 5-star hospitals. But you can see that A and C had insufficient data in heavily weighted category and had insufficient data in one of the heavily weighted categories and a lower weighted category. But yet they still received a 5-star rating by performing above national average in the heavily weighted categories. And then on the next slide, if you look at Hospital B, so they scored below national average in timeliness of care, but that's a lower rated category, so they still received a 5-star rating. And then finally on this next slide, this study looks at the weighting of the categories. So heavily weighted categories had significant variation among measures. So performing well on one measure could result in a high score in this category. And readmissions had the highest variability and may be an opportunity for hospitals to differentiate themselves. So again, we keep pointing to readmissions as being an excellent opportunity for improving your star rating. And then finally, on the last page, we're going to leave you with some resources. So links to some of the sites that we talked about in the beginning of the presentation. And this is how you access Quality Help Desk at QualityNet. So if you do not know how to access your hospital-specific reports, if you don't know who in your organization has the logins for that, or maybe somebody's left your organization and you don't know how to get rid of their name and put your name in the spot, you need to call these nice folks at this phone number, and that's probably the quickest way to get through and get that fixed, is just make that phone call and they can help you access your reports. So with that, let's open it up for questions or comments. I know that was a lot of detail, a lot of techie, or a lot of analytic talk. So hopefully that made sense to you all, though.
Yeah. So Linda, we would like to take a pause at this time and open the lines for discussion or any questions you may have for the Linda. Please, either you can speak on the phone or type your questions in the chat box. We'll give 30 seconds for people to put their thoughts together.
Hi, this is Vanessa Buss at Peace Harbor. And you had mentioned earlier that our CEOs and CAOs had access to the site. How do we identify who the other person is and or if we have someone else?
So that's a good question. Well, start with your CEO because he would have had to assign the person.
Okay.
So it would start with him and he would assign the second person. If your CEO doesn't know, then I would call that hotline that I just put up on the screen, the help desk, because they will help you figure that out.
Perfect, thank you.
Thanks, Vanessa.
Linda, there is a question. How do we know what performance periods will be used in the upcoming rating release?
So the data that I showed you, the performance period, so the data collection periods that I had on the screen in those green charts, that was for the December release. And what I suspect is that that just rolls forward for 1 year for the next release. And that's the most recent data. I just pulled that out of the QualityNet website. So they're going to continue with that formula. So some measures, as we saw, some measures required 3 years to collect data because maybe volumes aren't typically high for those measures. And some measures only required 1 year collection period. So those just kind of keep rolling forward.
Thank you. There's another question. Does the radiology measures tie into appropriate use criteria?
There were some medical imaging measures, and there were only 5 of those. But I had, honestly, I haven't combed through all of the measures one by one to see what else might be related to radiology. But efficient use of medical imaging was definitely the last group, that 5th group that we showed.
So Linda, I have questions. Do we get any kind of information from CMS saying that, hey, these are the hospitals who have never accessed reports, and do we try to reach out to them? Is there any kind of information which is provided to any of the organizations?
That's a good question, Seema. That's something, because like I said, I talked to myself as well as our hospital association here in Nevada. We get on the phone with CMS quite a bit to talk about star ratings. And that was a question I posed when I mentioned that, it looks like we have a lot of people not accessing these reports. I think that's a good suggestion. We could probably follow up with them and say, could you give us a list of hospitals who are not accessing these reports, if they can identify that? And if we can identify that, then we can reach out to everyone and kind of share that we know who is struggling with accessing the report. So that's a good question. I think that's something worth following up with HealthInsight in the CMS for.
Okay. And Linda, we have 1 minute for this question. Is there any incentive with increased reimbursements?
Any incentive for?
With increased reimbursement, I believe what they may be asking is if they become 5-star hospital, then is there any changes in incentives or any reimbursements? Do they get any extra financial benefits?
No, not really. Not directly related to the star rating, but however, some of these measures are related to your hospital readmission reduction program. So if you don't reach a certain threshold for that, if you don't show a certain amount of improvement, then you can receive a penalty. So that would be related to reimbursement. Another thing is it could just be a public image or reputation could affect your market share. So I know in Nevada we have a new law that states that every hospital must display their hospital star rating if they receive one in their hospital entryways. So that may have an impact on public image and perception and patient choice. But other than that, your star rating is not directly related to reimbursement at this time.
Great. We would like, at this time, we would like Holly to start her presentation. And if we have time in the end, we'll take a lot more questions.
Great, thank you. Can you guys hear me?
Yes.
Wonderful. So thank you. It's an honor to speak with you today about Asante Health System's journey to 5 stars. I want everyone to note that this is a very high-level overview, and I would be pleased to speak with anyone individually via email or phone call if you'd like to talk about specific strategies on specific measures. There are 57, now 59 of them, and I can't include all of the work done. Next slide, please. For those of you who may not be familiar with the Asante Health System, we are a small 3-hospital system that services Jackson and Josephine counties in Southern Oregon. Ashland Community Hospital is a 49-bed hospital located in Ashland, Oregon. Asante Three Rivers is a 125-bed entity in Grants Pass. It's a level 4 trauma center and an acute stroke-ready designated hospital. And Asante Rogue Regional is a 372-bed hospital located in Medford. It serves as our level 2 trauma center, primary stroke center, and American Heart Association accredited STEMI receiving center. Asante is recognized by IBM Watson as a top 15 health system for 6 years, and of course just recently received the designation of 5 stars at all 3 of our campuses. But how did we start this journey? Next slide, please. I really appreciate Linda's breakdown of the process. It is very similar to the one that Asante took and ongoing. As Linda said in her presentation, this is a journey, right? This is a marathon, it's not a sprint. And the first thing that we needed to do was understand the metrics. We started by examining each domain. What were our weak spots? Were there any low-hanging fruit? And what about bright spots? We also had to understand our organizational capacity to improve. While we are a 3-hospital system, resources always feel strained across 3 campuses. We had to assess the current teams, what work was going on. Did it align with CMS 5-star methodologies? What other things did it align with? What other incentive programs? And how did we stop siloed efforts? Even though 3 hospitals doesn't seem like a lot of hospitals, you'd be amazed what people end up doing in the corners at each one of the entities. We also needed to take a top-down approach. Now, I know many people feel that the concept of a top-down approach feels backwards to many new leadership lessons, but it was critical our CEO and executive team set the tone. It created organizational alignment. It allowed for us to move resources into areas of need, but it all started with us setting a goal. I love that Linda asked you all, what priority is the star rating? Many of you said hi. Let me ask you another one. Can you put in the chat right now, how many of you, before the first star ratings were published, set the goal of achieving 5 stars? I'll let you guys kind of answer that and I'll continue forward. Next slide, please. This is a slide utilized in many forums throughout Asante. I will tell you that our president and CEO of Asante, Roy Vineyard, in the fall / kind of winter in 2015, told the executive team and the quality team that we would go for 5 stars. We socialized those efforts at every level of our organization, and we utilized this slide to start the concept of why CMS moved to the star rating. We used this to talk to senior leaders, middle management, frontline staff on the why. At Asante, our mission is, Asante exists to provide quality healthcare in a compassionate manner, valued by the communities we serve. Achieving 5 stars was a reflection to our community that we believe in our mission that we set forth. Next slide, please. This shows our journey. We took the first measurement of data from April 2015 and did a dry run in August. From there, we understood where the gaps were, worked to align performance windows with effort. As you can see, it was not a linear battle. We took dips in some areas and made small improvements in others. The key was keeping a pulse on how we were doing. Our performance improvement team at Asante has key data scientists that could utilize the HSR to understand our performance. As the director of quality, as the chief of quality, we often can look at that data, but sometimes understanding a loading coefficient doesn't make sense to us. There are experts that look at those pieces. Find those experts in your organization. Next slide, please. For our performance improvement team and senior level quality leaders, it was important to understand the benchmarks and the weight of each item. At Asante, we focused most of our efforts on mortality, readmissions, safety of care, and patient experience. We did some small focused work on low-hanging fruit in other categories. For example, there were things like OP29 and OP30 related to colonoscopy that we could place hard stops for the providers to ensure that they correctly documented those procedures. It allowed us to gain 100% performance, and while it wasn't the end of it all, it helped some of our scores in the lower levels. Next slide, please. Our work on the 4 large domains needed to be focused. We started by looking at the work our current work groups were doing. At Asante, we had long-standing readmission committees, throughput committees, and engaged many patient experience efforts. But were they the right things for STAR designation? In some cases, yes. In some cases, no. With each work team, the quality department drove specific goals on the 5-star metric. That's a key thing that I want the people on this call to focus in. Quality explained the why, and we drove the goals for the organization. Quality driving specific goals and communication of why helped teams navigate the right pathways and made sure we were doing the right work. We made measures on our balanced scorecard, and the metrics, while they did not reflect how the STAR report scored us, it was in relatable terms to our staff. From there, we cascaded down information. We recognized that a SIR or a composite score doesn't resonate with frontline staff. And guess what? Frontline staff drive our quality, but they must understand it. For example, in safety of care, we focused on CAUTI and CLABSI efforts. We showed real-time compliance rates with our bundle components and gave updates on outcomes and made it relatable at the patient level. Yes, our top executives need to understand SIR, but that doesn't mean anything to a frontline nurse. They need to understand the harm that happened to Mrs. Jones after her surgery. With every metric, you need to think in terms of board to the front lines and back. What is the communication channel? We utilize metric dashboards, newsletters, real-time quality assurance, and our quick process observation boards. You can never communicate enough, but it has to be consistent. We also monitor our STAR status monthly. We have 3 entity-specific 5-star dashboards with all 57 metrics. It shows our targets, our current month, our change from the prior month, fiscal year to date, and our 12-month average. It shares what the performance windows are, what teams are working on it, and are we in a monitoring or pursuing phase. This allows clean communication with leadership on a level that makes it so these things are more real time. We don't allow us to wait for what CMS is going to always show us. We monitor internally and then check with what CMS is showing us. Next slide, please. But what obstacles did we face? There are a couple. Ashland Hospital. It's a very small hospital. It doesn't qualify as critical access, it's just small. This means the minimum requirements for many of the metrics don't count, and one fallout poses a very large risk to our overall rating. But for Asante, as we're thinking about all 3 hospitals, we have to balance how we shift and monitor resources. While Ashland Hospital may pose risk with one fallout, we have to think about the masses that we're serving at Rogue and 3 Rivers and prioritize where we put our bigger efforts. For all quality efforts, we do take a system approach, but taking a system approach is not easy. At Asante, it doesn't mean cookie cutter. When we look to improve, it's across all 3 of our facilities, but each facility serves different patient populations, they have different providers, and overall different staffing structures. We have to be agile to meet the needs of each entity. It can be challenging, but there's compromise, and all goals have to be clear at an executive level. Having your executive team engaged in this and setting the tone and the goals is key. Next slide, please. Some of the solutions, I talked before about our teams. We have multiple steering committees that function at a system level. That means between all 3 hospitals, and they cascade down information into entity-specific work. So sharing meeting time between all 3 campuses helps us problem solve, it helps us share best practice, clearly communicate goals, and it keeps everyone around the table accountable. For patient experience, we did only have entity-specific efforts. We had engaged HealthStream to support in the adoption of narrating care, bedside handoff, and hourly rounding. I know what everyone on the call is thinking. Hey, we've implemented those things too. All things we had implemented, but our scores never reflected that we were doing the quality work to really make an impact to the patient. Now, some of these efforts overlap. We've been on a 1-year journey to improve our discharge process. We have engaged post-visit call nurses who contact patients within 2 to 3 days of their discharge. They assess and quality check our discharge process. This information is shared with leadership and frontline staff on if our patients felt they received their discharge instructions, did they understand their medications, and did they get a follow-up appointment. It hits patients different than the patient experience survey and allows for the triage nurses to interact with the patient and get them information. If they didn't get a follow-up appointment, that nurse works to get them a follow-up appointment. So not only does this improve patient experience, but it supports decreasing our readmissions and improves our throughput. Next slide, please. Now, I know that this was very high level, and even putting this together, I thought, wow, it was easy. It was like there was an easy button to getting 5 stars. There was not. This has been a journey that we have been working on consistently since 2015. Linda asked, and I'll ask you again, how many people put this as a priority? How many people set that goal of 5 stars? At Asante, we did, and we continue the work towards 5 stars. We're trying to understand when CMS updated how they were going to look at the different metrics, we needed to understand how that impacted us. Do you know your areas of opportunity? I have on my desk right now all 3 of our entities' 5-star reports, and I can tell you exactly where we're at on each one of those metrics. Can your senior leaders speak to it? If I walked into your organization and asked your senior leaders, can they do it? Can the frontline staff tell you 5 things that they're doing to support quality? Keep your work intentional and focused. Don't try to boil the ocean. The final thought that I'll leave with you, driving good quality gets results. Focus on doing work that improves the lives of patients. At Asante, our vision is to be your trusted health partner for life, every person, every time. While it's easy to get caught up in chasing metrics, don't just check the box. Make your efforts for the patient and for your community. Thank you guys, and I will open this up.
Thank you, everyone. Here is the contact information for each state. Feel free to send us an email, call us, and we will try our best to help you. Any questions? Linda is, as we know, is very knowledgeable in this area. We have Laurie in Oregon State, Michael in Nevada, so please, and Linda in Utah. That's all for today. We'll be signing off now, and we hope you have a great day. Rest of your day.